morning, everybody. John Wallabin, Senior Analyst here at JMP Securities, and thanks for joining the second day of our Hematology Oncology Summit. Pleased to have BioCryst Pharmaceuticals joining us, and today from the team we have Chief Communications Officer John Bluth and Head of Research and Development Helen Thackeray. So thanks, guys, for freeing up the time and talk to us a little bit this morning.
John, thank you for inviting us to the conference. We're looking forward to talking with you. And Helen and I will both be making some forward-looking statements today as part of the discussion. So just want to invite everyone to please review the risk factors that you can find on our website and in our SEC filings.
Perfect. And for you guys dialed in, if you have questions as we're going through our conversation, feel free to enter them in the chat link below, and I'll weave them in the conversation as we get going. But Helen, maybe to start, I know you guys don't have any specific data at ASH upcoming, but I was hoping you guys could talk a little bit about your strategy. You've been looking at the complement space for many numbers of years. You have a late-stage asset looking at Factor D. Tell us a little bit about that target, why it's attractive, and what your plans are with your programs there.
Yeah, sure, John. So our strategy broadly is to develop inhibitors for various diseases that are complement mediated. The Factor D program is, for us, that's the first program in that under that strategy. We have two Factor D inhibitors. We're looking at Factor D because it is the first step and a critical component in the alternative pathway of complement, and is directly implicated in controlling and contributing to several diseases, including PNH, including some renal diseases. So our plan overall is to pursue inhibition of Factor D with oral Factor D inhibitors to contribute to treatment of disease, and then more broadly to continue to advance other molecules for other targets in the complement-mediated disease space.
Great. And the late-stage asset, BCX9930, it's your lead Factor D inhibitor. You have pivotal trials ongoing in PNH as well as complement-mediated diseases. But since we are talking about Hematology Oncology Day, maybe if we could just focus on PNH. Can you tell us a little bit about the data you've generated so far supporting 9930 in PNH?
Yes. So we, with BCX9930, we've been able to see in our program some what we think is very exciting efficacy data. So with that oral Factor D inhibitor, we're seeing increase in hemoglobin to the extent that patients are reaching near normal hemoglobin with freedom from transfusions or reduction in transfusions. And so that efficacy is very strong. With that program also, as you know, we've had safety signal with serum creatinine. And so we're balancing that. We're looking for that program, the strategy is get to a safe and effective dose, and to do so in the competitive environment with BCX9930. Our strategy is also to bring forward their second molecule, BCX10013, as an oral Factor D inhibitor that has the potential to be differentiated as best in class once daily.
And you mentioned, the potential safety concerns with 9930. Can you walk us through what you saw and how you guys are looking to mitigate and explore, the path forward with 9930?
Yeah. So what we saw in the spring, we saw a rise in serum creatinine in some patients who are on our trials with BCX9930. We saw it at the 500 milligram dose level, and we halted enrollment. At that time, we also, the FDA put a partial clinical hold on that program. The FDA lifted the partial clinical hold in the summer, and we reinitiated work towards the trials. We announced recently that we've reopened to screening in those trials, and we'll be planning to enroll a new set of patients at a reduced dose, going from 500 to 400 milligrams twice daily. And we think that with that reduced dose and simple hydration, we're looking for being able to see improvement in serum creatinine, in fact, not observing any further rises in serum creatinine. And we believe that combination of a lower dose and simple hydration may reduce the concentration of the drug in the kidneys in patients and thereby prevent what we think was crystals forming in the kidneys. And so we're looking for a resolution of that.
And if I remember correctly, we'll get an update next year on what, a go no go decision in terms of how 9930 is affecting serum creatinine, but are we also going to get a look at efficacy when you take a look then early next year, or is it just going to be on the safety side?
So we'll be making a decision on the program, as we've said, because we intend to bring a drug that is safe and effective and competitive in the space. So it will be a combination of those factors that is the basis of any decision we make. Safety is clearly a critical piece of that, but efficacy and being able to be competitive is also part of the picture for us.
And yeah, mentioning the competitive landscape, we're going to have what I think is going to be interesting data from an oral factor B inhibitor, ibidacofan, at ASH next week from Novartis. They had what I thought was pretty interesting phase 3 PNH data. AstraZeneca has some data for their factor D inhibitor, so more similar to 9930 in your next gen. What are your 2 cents on the data we've seen from those programs, especially through the lens of what you've seen with 9930 and then also in-house with 013?
So we will also be at ASH. We'll be there to see the data as it's presented and learn more beyond what's been presented in the abstracts. I do think that the Novartis abstract data set shows very good efficacy, and so it'll be interesting to see what else they give us in that data set, including, for example, things like what kind of patient population have they enrolled to see that efficacy, and are there any points in the data that they've excluded from what was reported, for example, breakthrough episodes that might happen in the context of something like a COVID vaccine. So I'll be looking for that kind of thing. And similarly with the AZ data, that's preliminary. That's not pivotal data from what I recall, but they also have what looks like efficacy that's very interesting, and I'll be looking to see more of what they are reporting. In the context of our program, we'll be looking at that because this is the competitive landscape that we need to contribute in order to bring a differentiated product forward. And that is our plan, to bring a differentiated product forward. And we have both molecules, 9930 and 10013, which we are evaluating for that.
When investors are taking a look at a PNH data set, what's kind of important things to keep in mind or to look at? The story's changed over the years from LDH to more hemoglobin and transfusions and even fatigue scores. But is there anything that people should keep in mind as they're trying to interpret these data sets? Like, for example, are there differences in transfusion requirements in study? Is it up to the investigator? Does a patient come in and say, I'm feeling very tired? How do we think about interpreting this data when we see it?
It can be a little complicated because it depends on what's being reported and how it's defined. The most important thing in PNH when you're looking at a treatment is, can you improve the hemoglobin? Can you prevent the hemolysis, both intravascular hemolysis and extravascular hemolysis? And so that the oral factor D inhibition approach allows you to get the extravascular hemolysis as well. And that's what we've seen is improvements in hemoglobin to a significant degree. But you also then look at what else is happening, the things you're mentioning, whether transfusions are reduced, the need for transfusions, whether they're in fact avoided. In the clinical trial data, it can be difficult to interpret that because data is reported differently. Some trials will ask the investigator, when are you transfusing? And it is a medical decision that's made differently in different circumstances, so it can vary.
Mm-hmm.
And so this is one of the things I'll be looking for when I go to ASH and see the other presentations that are being given, is how are they defining transfusion and need for transfusion? Are they defining it as an investigator-based decision? Are they defining it with something that's consistent across the protocol? You mentioned LDH. That's another marker. It's a marker of intravascular hemolysis, and it's something that you want to see controlled for ultimate disease control. However, the most important thing is what the patients will feel, and that's hemoglobin and anemia and the fatigue that goes with it, and their experience in terms of needing transfusions.
That's super helpful. Let's hoping to talk a little bit more about your next gen factor D inhibitor, BCRX 10013. You guys mentioned some healthy volunteer data recently, and you talk a lot about the differentiation from the competition. Can you talk about, 013 and then especially how it's different from 9930?
Yeah. BCX 10013 is how we're saying it, although that's just simpler.
I haven't said it out loud till today. 10013.
It's a mouthful, as early names are for drugs that are still in development. We're very excited about that molecule. It is so it's got a chemical framework that is quite different from BCX 9930. It's a different molecular entity. There are some similarities in the framework. There's important differences. One thing that we're seeing is that the pharmacokinetic profile of the drug in our human data so far, which encompasses about 90 people in the studies, is showing clear potential to have once daily dosing. We need to confirm that in patient studies, but what we're seeing there is a difference from 9930 in the PK profile that supports the potential for once daily dosing. So that does two things for me. That both gives us an opportunity to bring forward a differentiated molecule. It also demonstrates the difference between the two. The other thing that we've spoken about previously, and I'll raise here also, is that with 9930, we did have a chance to learn that in the preclinical data, we could observe crystals forming in the doses, especially at higher doses. We had a chance to do some of that work with 10013 as well, and we do not see crystals forming in the same way or in the same setting. So that is another point that I would say in support of them being completely different molecules. And with 10013, I want to come back to, we're excited because this is a second oral factor D inhibitor that we think has the potential to be safe and effective. We have to demonstrate that in patient studies, and that'll be our task in 2023.
Got it. And we're going to get some healthy volunteer data, I believe, first quarter for 10013. When we think about, a factor D inhibitor, alternative pathway inhibitor, what can we learn from a healthy volunteer study? What biomarkers should people be looking at to show us that this is, doing what you're expecting it to do?
Yeah. So the basics, we'll be looking for safety and pharmacokinetics, and we'll be reporting what we see for those. But pharmacodynamics, measures of the drug's effect on the body, can also be reported in healthy volunteers. And the complement system is present and active in healthy volunteers. So biomarkers, PD markers that can assess activity on the complement system can also be reported in healthy volunteers. And so you can expect to see some of that.
Got it. And how are you thinking about, the best use for 10013? If 9930, if you get through the safety and everything looks okay, that's in a pivotal for PNH. Would it make sense to bring forward 10013 in PNH? I know there's a bunch of different therapeutic indications. PNH is getting a little crowded. I have to imagine development gets more and more difficult with more people in the ring. But how are you thinking about, the best use for 013? Is there some other better indication given its profile? How are you thinking about, moving that forward?
Yeah, we would move 10013 into some of the broader diseases and larger indications, probably some of the renal indications initially. It would have the potential to be relevant for any disease where an oral factor D inhibitor could be useful, but our focus would be on probably some of the larger renal diseases first.
Interesting. And I know we're bumping up on time. I wanted to end on one for people to think about, the future. You guys have been looking at the complement system very broadly and in depth, and I know you guys always have things moving in your discovery engine. What other targets are interesting, do you think about? We've seen C5 be successful, C3 now, factor D, factor B moving forward, but, every year it seems like there's some new, target someone's going after. So, what's interesting to you in the space from a target perspective?
What's most interesting to me in this space is that there are many targets, and there are targets that are enzymes like serine proteases that we've been successful with developing inhibitors to date several times. There are also other proteins that are of interest, and so to me, it's the breadth of opportunity. What I can say is that we have discovery work that's proceeding in several different targets in the complement system. I'm not prepared today to disclose those targets, but we will be back with that information. But they are beyond the alternative pathway. We're looking at things that could be useful in diseases that are mediated largely by the other pathways in the complement system, and then possibly if you have an oral monotherapy that for one part of the complement system and oral monotherapies for other parts of the complement system, there's the opportunity maybe to combine them for diseases that have aspects of more than one pathway in the pathophysiology, more than one complement pathway. Combining those could be useful.
Interesting. Well, I know you guys have had success both looking at de-risk targets and making better molecules, and also drugging targets that others have hadn't had success with yet. So, looking forward to all that. But with 9930 and 10013, you guys got a lot of work to do, and we're looking forward to the updates next year. So, thanks again for freeing up the time this morning and giving us a rundown about all the programs. We appreciate it so much.
Thank you very much.
Thanks, John.
Thanks, everybody.